So hypertension is probably the bread and butter of family medicine. Almost all of our patients, well, a large percentage of our patients that we see, even if we see them for other comorbid conditions, might also have hypertension. And it's one of those common things that we manage every single day and that gets managed very badly overall. So when they have done studies specifically in South Africa looking at how many patients are actually on target for their blood pressure and are on the correct treatment for their blood pressure, the stats are shockingly low. So we have very good, very evidence-based guidelines available on hypertension, but one of our challenges is we are not implementing those guidelines. And I think partly because there's so much happening in the world of hypertension, sometimes people are not staying up to date. So at the moment, the main reference guideline we use is a practice guideline that came out in 2014. And that practice guideline vastly informs what you will read in your EML. In 2020, the International Society brought out a practice guideline. And I will be showing you how the EML is going to be changing within the next 6 months to accommodate some of those recommendations. So I'm going to be teaching you where we are, but also where we are actually going in terms of hypertension. So how do you diagnose? Very simple, very easily. Please remember our cutoff at the moment is still 140/90 is our diagnosis of hypertension. But very important, never ever use one reading to either make a diagnosis or make a decision about treatment. So remember, blood pressure is not just about the fact that our blood pressures go up and down in the day. It's about what your baseline blood pressure is. So if you're in pain, your blood pressure is going to be up. If you've got a full bladder, your blood pressure is going to be up. If you've just rushed and sat down for your blood pressure is going to be up. That's not hypertension. Hypertension is what happens with your blood pressure at rest. And so it's very important to watch out for that single blood pressure that you get that's been done by a nurse in the front when you don't know what the circumstances were. So if you're going to make a major decision about blood pressure, you need a few readings. And if you're about to decide to put somebody on blood pressure treatment for life or diagnose them with hypertension, you want 2 or 3 readings over at least 2 or 3 visits, and usually within a 2-week period. So if you see somebody for the first time ever today, you're going to ask them to go back to their clinic. You can even write a note in the book, and you're going to ask them to come back with blood pressure readings from their clinics before you're going to make a decision. Once you have those readings, that's when you're going to decide to grade your hypertension. And we're going to look a little bit at those numbers today. And in South Africa at the moment, we're still using 140/90 when we start getting excited. Internationally, there's a lot of discussion about what we do between those, 130 to 140 group or between the 80 and 90 group. But for our purposes, over 140/90 is when we actively start to intervene. Most importantly is making sure you do your blood pressure correctly. If there were students here, we would be interrogating them now on blood pressure technique. Please go and read up. Make sure you know how to do a good blood pressure. Make sure there's very nice, both in all the guidelines, there's some very nice, but very important there is that when you sit down and do that blood pressure, if you go to the nurse's station, make sure you do it yourself. Don't just send it for the nurses to do it. Make sure your patient's rested and sitting in the correct position, et cetera, et cetera. And then take 3 readings 1 minute apart. So your patient's is relaxed, sitting down, empty bladder, hasn't eaten, sit in the right position. And then you take the average of the last 2 readings to come up with that blood pressure that you're now going to use to classify your patient. So these are the algorithms that you will find. The one on the left is from the 2014 guideline, and the one on the right is from the EML. They're basically saying exactly the same things. But I'm going to, and this is what we're going to be covering this morning, but I want to cover on what's going to be happening very soon as they're updating our EML. This was from a national EML. They actually had a meeting, like a Zoom meeting, to show the changes that was being implemented. It was chaired by Prof. Parrish. So we have solid reference there. And this is a screenshot from that actual talk in terms of the algorithm that will be in the new EML. We're actually, to a large extent, already using this in our practice, especially in this OPD, because we've been very aware of what's going on in the international guidelines. But what's happening at the moment is mostly the issue is not the fact that the guidelines have slightly changed, but we haven't even been implementing the old guidelines. So just being aware of where the new guidelines are, and if we're implementing these well, we actually are not too far off even from where we were in 2014. So let's start in terms of being able to understand the principles of where do we start. So hypertension has got steps. You all know this. You start with lifestyle, right? Then there's one drug, then there's two drugs, then there's three drugs, and there's 4 drugs. So there's these steps in hypertension. But depending on your patient will depend on which step you're going to enter at. And that's the thing that's changing at the moment. So how quickly and how aggressively should we be starting antihypertensive treatment, and how many drugs should we be starting patients on? And it has to do with the risk of your patient. So we're going to talk a lot about risk, qualifying your risk of how aggressive you're going to be in managing your patients. And there's a few big numbers we're going to look at. So the first threshold is that over 140/90. Remember, you've determined this over a couple of weeks. Your next big threshold is 160/100. So these are numbers to remember. And then we know about urgency, emergency, and asymptomatic. I'll talk about that for the over 180/110. So that's the person who's sitting on the front, and the nurse has made that nice big round red circle around it. But in the new EML guidelines, they specifically also talk about those that have a blood pressure of over 200/120, and they differentiate those are severe and with needing aggressive intervention. So in terms of initiating patients, so these are patients who's never been on hypertensive treatment before and who you're diagnosing for the first time. Group number 1 and 2, the 140/90, the 160/100, those you've actually diagnosed by using a week or two of getting different readings, making sure you've done your reading correctly. If you were in private, you might send them a blood pressure machine home, done all of that. And this is where their blood pressure is consistently sitting at. So if it's consistently sitting at 140/90, you need to look at the risk factors. If they've got no risk factors, so these are completely well patients, no cardiovascular disease, no end organ target damage, and no risk factors at the moment for cardiovascular disease, those are the only patients where you might consider lifestyle intervention, and only for 3 months. So it's not an ongoing, let's try a bit longer, let's try a bit longer, let's try a bit longer. This might be still a relatively young person who's relatively fit, got a little bit of tummy fat, a little bit unfit, blood pressure sitting 150, 45, 95. And you can say to him, listen, you're probably going to end up on treatment, but if you want to try lifestyle for 3 months, we can do that. After 3 months, in those low-risk patients, otherwise, but the blood pressure is still sitting over 140/190, we're going to start with a 1-drug regimen. Okay, easy. Once the blood pressure is 160/160/100, so again, you've done your 2 weeks, you've had readings from the clinic, you've got your 2 readings you've done here, you're going to start those patients right onto step 2. So this has been the major change. So we're not going to muck about with hydrochlorothiazide for a while and see if that helps. We're not going to muck about with lifestyle for a while. We're going to go straight for 2 drugs at their lower dosages. And I'm going to give you the details of those drugs in a minute. We're going to go through that. So this is our entry into those cascades. If they're over 200/120, then obviously you're going to deal with them depending on whether they've got urgency or emergency and all of that. We will look at that. This is new patients, remember, but you're going to start them on treatment on that day, and you're going to start them on 2 drugs at full dose. So you're not going to start the lower dose of the 2 drugs, you're going to start the 2 drugs at full dose. And of course, with all of these, if they're not controlled within 2 to 4 weeks, we're going to step up the treatment. But this is your entry into the cascade. And I think the major difference is that we're going to have a lot more patients. We're actually going to start on 2 drugs from scratch. And this is already in the 2019 EML, where they make the statement that 60 to 80% of patients is going to need combination antihypertensive treatment. We know this. Most of them you're not going to control on 1 drug. So this thing of sort of hanging on to hydrochlorothiazide for months, hoping will make a difference, is much more of a drive. Get them onto those 2 drugs earlier rather than later. And that's now, the new guidelines now recommends that very strongly. So of course, that makes the difference is whether your patient is risky or not. So 160/110, that's quite straightforward. But if they've got a blood pressure of over 140/190 and they've got 1 or more risk factor, they're also going to start on those 2 drugs. So how do you decide what the risk is of your patient? So firstly, there's the blood pressure. So we talked about mild, moderate, and severe in terms of those different thresholds for blood pressure. But the risk factors then gives you this nice little graph. And this is actually, now it's going to be in our EML, but that's actually taken from the international guidelines. And you can see it has to do, the more risk factors you have, or if you've got actual disease, the higher your risk is. And if you are low risk, you're going to start on step 1. If you are medium risk, you're going to start on step 2. If you're high risk, you're going to start on step 3. So what do we mean by cardiolist risk factors? So there's various lists for cardio. These are all the stuff you know, right? Right. But just to remember, so anybody obviously that smokes, dyslipidemia. So we're waiting in the new EML. These are old numbers if they're going to be more creative in terms of that and put triglycerides in as well. Obviously, anybody with diabetes, men over 55 and women over 65 years. So all of your elderly patients will end up going onto 2 drugs, remember? Family history of early onset cardiovascular disease. And then abdominal obesity, they're busy updating these graphs. So this is still relatively old information. And I know that they are busy bringing down those thresholds. So in the old days, we said if your waist circumference in men is over 102, problem 80 in women. That's what's still in the EML at the moment. But the international guidelines has actually got it down to 94 centimeters for men and 80 centimeters for women. It's not very much. In terms of a cardiovascular risk factor. Notice for South Asians and Chinese is actually different thresholds. Already mentioned in those EML slides is they're also looking at a heart rate of more than 80 beats per minute. I found that quite interesting. And early onset menopause. So in these scenarios, if the blood pressure is over 140, 190, and they have even one of these, you're going to start them on 2 drugs. So that's a huge shift from where we used to be, because almost all our hypertension patients has at least one of these. And then the obvious ones is that they've already got complications. So there's what we call hypertension-mediated organ damage, HMOD. So classically, that's our left ventricular hypertrophy. That shows that heart's been working hard for a long time. If there's microalbuminuria, unfortunately, we have to use our UPCRs to measure that. And if there's early retinopathy, that shows us there's complications starting. And of course, anybody who's already got coronary artery disease, is already in failure, has already got chronic kidney disease, has had a stroke, peripheral artery disease, and has already got advanced retinopathy, those patients are all high-risk patients. And so if they've got a blood pressure of over 140, 190, they're going to go straight onto 2 drugs. So how do we assess our patients? We've now made our diagnosis, we've decided where they're sitting. And you basically want to try and see what their risk factors is. That's your biggest thing, because you can't decide what drugs you're going to put on unless you know where they are in terms of risk. So you want to look at general examination, you're going to look at that waist circumference, and very important, all our hypertensive must have an ECG at baseline. And what we're looking for specifically is left ventricular hypertrophy, and you're going to go look up the criteria for that this weekend. Your urine dipstick, important to see a baseline. And if it's abnormal, if there's any protein on the urine dipstick, you can send a UPCR. The problem with a urine dipstick is it doesn't pick up microalbuminuria. So you have to have quite a bit of protein already before you're going to see anything on your dipstick. So if you've got a patient who's got risk factors, you can actually consider doing a UPCR, even if the dipstick is negative, if you're concerned about their GFR or their risk. And then your baseline blood. So for hypertension, because we're going to be putting them on diuretics, we want a full cusp. We want the electrolytes as well as the creatinine at baseline. We want to make sure they don't have diabetes. You can just do a finger prick point of care to screen for that. And if the patient's got any history of gout or possible risk, you want to know maybe what their uric acid is doing. Our target is 140 over 90. So this is one of those hotly debated things. So already when I worked in the UK, God, more than 15 years ago, they were already bringing those thresholds down to 135 or 85, for example. In South Africa, we're not even doing the 140-90 target very well. And just resource-wise and expense-wise to set a lower target is not practical. So we recognize that the evidence are there for lower targets, but in practice, if we could just get everybody under 140 or 90, we would already be making a massive difference. But even in the KDIGO guidelines, specifically on patients with kidney disease, if you've got a patient with diabetes and a low eGFR, it's very worthwhile to consider a lower target and getting that blood pressure as low as possible, even under 130/80. So very important, before you change a blood pressure, before you add extra drugs, make sure you check that blood pressure at least 2 times or 3 times using that correct measuring technique. When you start your patients, you're going to see them every 2 to 4 weeks, depending on what's convenient for your patient. 2 weeks would always be the ideal, but 4 weeks end up being what patients can afford until your blood pressure is on target. And remember in your younger patients, again, that's not something I'm going to cover here at all. If they are less than 40 years, just consider that there might be a secondary cause, especially if they've got those higher blood pressures and no other obvious risk factors. Great, you're also on board. Excellent. So let's look at what we do. Step one is so lifestyle is, I'm not going to talk a lot about lifestyle. We've heard about diabetes as well, that lifestyle can have a massive impact. Counsel our patients, that's going to be patient's job. Our job is the drug treatment side. The step one at the moment is still hydrochlorothiazide. They did look at the evidence of indapamide, but it's not going to be in the new EML. We're still going to stick with hydrochlorothiazide for the moment. You start with your 12.5 milligrams per day, and we're going to stay, going up to 25 does not make a massive difference. So if your 12.5 is not bringing the blood pressure down, you're going to go straight to step two. Step two, you choose your second drug, and you've got one of two options, either amlodipine or enalapril. So in our public sector setting, it will always be one of those two drugs. For Black patients, we know amlodipine is a better choice. It's got better effect, so we would choose our amlodipine first. But there are specific scenarios, and I will run through them, where enalapril is preferable. So you will look at your patient, and depending on what else is going on for your patient, you might choose enalapril instead of amlodipine. So our dosing is there. You're going to start with your amlodipine 5 milligrams. The EML tells us we can start with enalapril 10 milligrams nocte. So that's interesting, a once a day dosing. So the 2.5 BD is more on the heart failure, right? And your elderly patients where you might start much lower dosing. But in our average patient, we're going to start on enalapril 10. And then you're going to, your step 3 then is actually when you go up to the next dosing for that drug. So with amlodipine, that means going up to 10. And with enalapril, that means going up to 20, right? So that's step 2 and 3. Couple of just highlighting things on each of these drugs. So hydrochlorothiazide, just keep in mind a history of gout specifically, because you might precipitate a nice gout attack if you're not careful. Dr. Kayembe has done 2 excellent talks on gout, and one whole section is just about uric acid and hypertension. So very useful just to have a look at that. And unfortunately, hydrochlorothiazide is not particularly useful once the kidneys start failing. So usually by the time your GFRs start dropping dramatically, you're going to have to look at another option. Amlodipine, as I've said, is actually one of our nice, you'll notice there's not too many compelling contraindications. There's a few cautions to watch out for. We don't really like them in the heart failures with a reduced ejection fraction as much. We'll prefer our enalaprils. But this has been shown specifically useful for our African patients. And therefore, our guidelines are sometimes a bit different than Europe, where they might have gone for the ACE inhibitors first. So great, so we've done step 1 and 2 and 3, now we're up to step 4. So this means the patient's on 2 drugs, blood pressure is still over 140/90, and we now need to step up to the next step. And now depending on which drug you don't yet have in the mix, you're gonna either add your enalapril or your amlodipine, and your patient will now end up being on 3 drugs, the hydrochlorothiazide, the enalapril, and the amlodipine. If they're still failing at this point, you can, if you're not desperate to go on to 4 drugs, change the hydrochlorothiazide to 25. The evidence is that it doesn't do dramatic differences in terms of blood pressure. That might be useful, for example, in a heart failure patient to have a bit of extra diuretic on board, so it might be worth in somebody like that. But quite often, if you're failing at step 4, we're now going to move on to step 5. And at step 5, we actually now call this resistant hypertension. So there's a definition that if you're on 3 drugs, of which 1 drug is a diuretic, and your blood pressure is still not controlled, and you made sure it's not white coat hypertension and the patient's actually taking their drugs, then we call that resistant hypertension. And the number 1 choice drug for resistant hypertension is spironolactone. So you're going to start off on your 12.5 milligrams, and you can titrate up to 25 in terms of hypertension management. And remember, we want to not go, if the GFR is under 45, or if the potassium is over 45, we're going to have to be careful with, yes, that's a mistake. It's GFR under 45 and potassium over 4.5. We need to be careful with spironolactone. So just to look a little bit at those drugs we've just discussed. So in enalapril, there's a few places where enalapril is first choice. And the 2 you basically have to remember is in heart failure patients with reduced ejection fraction, all of them are going to be on enalapril. So if you've got a patient with heart failure, even with preserved, and they also have hypertension, your number 1 choice is your enalapril over your amlodipine. And enalapril is one of the only drugs, the ACE inhibitors, that has shown some benefit for patients with proteinuria, our diabetic patients with leaking all those proteinuria. So in your nephropathy patients, you will also choose your Enalapril over your Amlodipine to help those patients. So just remember with Enalapril, our big challenge with Enalapril, when you think Enalapril, you think hyperkalemia, right? And therefore the rule is any patient that you put on Enalapril, 2 to 4 weeks later, you've got to do a potassium. So we all know our lovely system down here. It's very easy to do for the patient to go and have a potassium done a couple of days before we see them. Whenever you initiate Enalapril or whenever you increase the dose of the Enalapril, remember to do that potassium and just make sure we're still safe. What's interesting with Enalapril is even though it's our favorite drug for proteinuria and for reduced eGFRs, it can actually make the serum creatinine go up by almost about 20 to 30% in some people. It usually happens in the first few weeks of either adding or changing the dosing. And as long as that creatinine has not gone up by more than 30%, that's not a problem. You can keep them on the Enalapril. And then spironolactone. So another place where we love using spironolactone is obviously in resistant hypertension, is for patients with heart failure with reduced ejection fraction. And spironolactone as well as carvedilol are both drugs that actually influences mortality. We'll talk about that in a minute. And therefore is one of the key drugs you'll probably pick if somebody has got hypertension and also needing something for their heart failure. The only problem there is remember that GFR is under 45 or those potassiums over 4.5. So sometimes you might have run into trouble because maybe your patient is now resistant to all of those drugs in terms of hypertension. Now you really might need to make sure they're taking those drugs and what's happening with their blood pressures at home, send them to the clinics a few times, double check. Or maybe they can't tolerate a drug. So with Enalapril, we know we get that dry cough, or very rarely you can get some angioedema. Maybe the losartan is causing the same trouble, and now you've got to use something else. So we've got a few other options of drugs we can swap in and swap out. A lovely one is hydralazine, 25 milligrams 3 times a day that you start. You're going to build that up to 75 milligrams 3 times a day. Can cause palpitations, so it's quite nice to combine it with a beta blocker. Our patients with prostate, with benign prostate hyperplasia, one can use doxazine. Start with 4 and build up to 8. In the EML, but I think that will shift, they still have atenolol under the resistant hypertension section as an option. But we prefer carvedilol. It's more cardiac friendly and has less of the other side effects and long-term effects, especially because we don't want to use atenolol in metabolic syndrome, which all our patients have who's got hypertension. And you're going to start on 3.125 milligrams BD, and you can build up to 25 milligrams BD. And if your GFR drops under 45 and you can't use hydrochlorothiazide, then you can replace with furosemide. Remember then to always give it as a BD dose, or you won't cover the blood pressure for the whole 24 hours. And you're going to start with a 20 milligrams BD and you're going to build up. Great. Guys, not glazing over quite a bit. So just a couple of highlights there. So for carvedilol, also first choice in heart failure, reduced ejection fraction. But remember, our beta blockers is problematic for our asthmas and our PDDs. Furosemide in those lower GFRs. And of course, we're using it in heart failure for symptom control. Hydralazine is a nice option in those low GFRs as well. So those are just some of your highlights there. Once your blood pressure is now nice and stable, then you're going to check your blood pressure, obviously, at each visit and check for side effects. You're going to do that every 2 to 4 weeks until on target. And once they're stable, usually 6 monthly visits is absolutely fine to see how they're doing. You're going to do your bloods every 3 to 6 months, depending on what your bloods are doing. So if your patient's stable, they don't have any risk factors, the bloods are all normal, then 6 monthly is fine. If they've got a low GFR, then 3 monthly might be necessary. And you want to do a creatinine and eGFR, and you want to do potassium and maybe sodium, depending on what the history was. But that potassium and creatinine is most important. You want to do your urine dipsticks, remember, every 3 to 6 months. And you want to do that lipogram and make sure they're on control. And then on the annual screen, so once a year, we should be, and I don't think we're very good at that actually, we should be doing yearly ECGs because we're screening, remember, for possible damage to different organs. We should be checking a urine PCR at least once a year, so even if the dipsticks is negative. And we're looking for other signs of end organ damage. And I think by next year, we'll probably look at maybe starting to screen our retinopathy and our hypertensives as well. We've been focusing on the diabetics at the moment, but that will also be sensible. So this is just a table to be aware of, that if your patient's got very complicated comorbidities, then you want to get clever in how you combine your drugs. I'm not going to spend time on this. You can go and look it up when you see patients like that. But we've already mentioned, for example, in CKD and chronic kidney disease, that our RAS inhibitors, our losartan or enalapril, first, losartan second, are first choices there. We've already spoken about in heart failure, wanting to use our beta blockers and spironolactone, etc. So you will choose your drugs that will be both for both your comorbidity as well as your hypertension. And what's interesting, and that I always forget it, and pharmacists always remind me, is that there is a drug interaction with amlodipine and protease inhibitors, and there's a level on how much amlodipine you can give. I can't remember. Can you give it at all? Do you remember? The pharmacist always comes and complains if I've got them on amlodipine and lopinavir, yeah. No? Yes, maybe I've got that wrong. I'll go double check that. That table is from somewhere. So just a last thing, a couple of things on severe hypertension. So quite often when you are sitting down in OPD, the nurses might bring us a folder and say, this patient's blood pressure is over 180, over 110. And there are 3 levels you want to look for. And the asymptomatic ones, you want to be able to examine those patients and make sure there's no symptoms and there's no progressive target damage at that point in time. And remember, some of those patients might have had a high blood pressure for quite some time. In those scenarios, you want to let them rest for a bit. You want to repeat the blood pressure again after an hour. We're not going to do massive interventions yet to make sure that it is staying at that level. And if they're still high and they're a new patient, then you're actually going to start them on 2 antihypertensive drugs. You're going to go straight for step 2 on that day. And you're going to send them home for that and see them in a week's time. So for the asymptomatic guys, we're not going to try and feed them drugs in casualty and just try and get it down in casualty on the day. They probably have had that blood pressure for who knows how long, trying to now dramatically do something and watch for them to go down on that day. It's not going to serve any purpose. But we are going to start them on treatment. If they're already on hypertensive treatment, whatever step they're on, you're obviously going to go step up on that day again, and then you can follow them up quite quickly to make sure you've got that under control. It's more important that you've got to look off is your hypertensive urgencies. So these are patients who've got a very high blood pressure, again, over 180, 110, and they're symptomatic. So either a severe headache, or they've got some shortness of breath, or a little bit of edema, but it's not a life-threatening immediate complication. It's also not something that suddenly happened. They might have been feeling a bit unwell with it for a few days, for example. The EML and the new EML confirms that these patients should be admitted, and that one would actually start them on the 2 antihypertensive drugs and monitor them over a 48 to 72-hour period to get that diastolic down, and you don't want to get it down too quickly. And they would usually, the drugs of choice would usually be amlodipine or enalapril, unless the sodium is under 130, and then later down beta blockers, hydrochlorothiazide. But that's a hospital admission protocol that'll be followed. And then hypertensive emergencies are patients who comes in with a very high blood pressure, but they're actually going through a life-threatening complication at the moment. So hypertensive encephalopathy, so that's where they have those severe headaches, visual disturbances, confusion, seizures, coma. They're coming in with an actual heart attack or some unstable angina. They've got acute left ventricular failure with pulmonary edema. If they've got eclampsia or severe preeclampsia for our pregnant patients, your acute kidney failures that's actual encephalopathy, and acute aortic dissection. And these patients are going to go straight to ICU, and they get treated with IV labetalol in an ICU setting. So we're not going to be getting people IV labetalol in OPD to get their blood pressures down so we can send them home, right? They go straight to ICU and they'll be looked after there. So that was a very quick run through for hypertension, and you're all going to go and read your guidelines to get some of the extra details. You still with me? Excellent.